What I will be doing is kind of walking you through this issue that has been the primary focus of my work over the last, 17, 18 years, which is the health and healthcare, the physical health of people with serious mental illness, really thinking about them as a health disparities population, but also, given that this is a research seminar, thinking about this link between research and practice, or what is often a lack of a link, and how that's kind of played itself out through the years with this issue that was really an issue that we knew a lot about for a long time, and only recently have begun to really seriously engage with. I want to start by just kind of, so we're all on the same page, identifying what the problem is that we're talking about, and pretty much I would say this problem can be summed up in a chart. And this is a chart that was from a paper, and it's from a paper that was published in 1930. And pretty much most of what came through in this paper and an accompanying book by an epidemiologist from New York State are really the same issues that we're struggling with now. So in New York State, the Department of Mental Hygiene, starting in 1905, began keeping very detailed records of what happened to their patients and and mortality, both causes and dates of mortality for patients after they left the hospitals. And what you see in the study, this is an epidemiologist from the New York Department of Mental Hygiene. What you see here is a major gap in the rate of mortality for patients treated in this New York State hospital system compared with the state population, and exists across gender groups and also across age groups. What's interesting is if you actually go back and read this book, he says this is not a new problem. This is a problem that had been known about for more than a century, and he cited earlier studies going back to the early 1800s, and said at greatly varying intervals in different countries and with different types of death rates, there is complete agreement upon the fact of the excessive rates of mortality among the insane. So really what he brought to this was a more rigorous, really trying to look this at more carefully, a larger sample, and carefully breaking it out by age and sex. So in this study, as today, the most common causes of death in inpatient psychiatric facilities were the same seen as those in the general population, most notably cardiovascular disease. He also noted the puzzling finding that we've kind of rediscovered, that rates of death from cancer were actually lower than in the general population. And again, both of these findings are really, the same ones that we're, kind of finding again and again, rediscovering today. So he goes on to speculate about the causes of excess mortality among psychiatric inpatients, and says, the high death rates of institutionalized insane may be attributed to the combined influence of physical and mental factors. There are also indirect effects due to the fact that mental disease causes irregularities in nutrition, injuries, and external influences. Another factor tending to increase the relative death rate of the insane is that of economic and social status. So as we'll talk about when we kind of start drilling down into some of the causes, these are really a lot of the same reasons, the problems that we're seeing today that are underlying the cause of excess mortality. So, very nice study here done, very rigorously conducted, beautifully graphed, days before Excel, by hand. What was the impact, nationally? Pretty much zero. What was the impact even in New York State Department of Mental Hygiene? Pretty much zero. I mean, these work, pretty much just went, onto a shelf, as so much of our research does. So, there was kind of a small industry in the 1970s and 1980s doing these mortality studies of psychiatric patients. They're kind of easy to do and pretty much come up with very consistent findings when you do them. This is an editorial that was in the Archives of General Psychiatry in 1985 by Ming Suang, who was an epidemiologist who did a lot of these studies, who said, do we really need any more of these studies? We kind of know this finding. It's just very well established. What's interesting about these studies that were done in the 1970s and the 1980s was they almost exclusively focused on the unnatural causes of premature mortality. So that's suicide, accidents, suicide in particular. And I would argue, this may be, a few factors. One is, this is a field that's kind of coming into its own. We were specialists. Suicide is, the worst possible outcome that we as mental health clinicians usually think about. But, it also reflects the way that we researchers tend to look for the sorts of things that we're trained to look for. And it's a little bit, again, like the drunk looking under the lamppost for their keys, because that's where it's light. So we saw death, and we saw, what we thought of was the problem of suicide and these unnatural causes. I think there's another reason also why we focused so much on these unnatural causes. And this is kind of a difference in perspectives and in different ways of looking at statistics. The relative risk of excess mortality due to suicide in patients with even schizophrenia is sixfold, so a really big relative risk. And that's much larger than the twofold increase in cardiovascular disease. So relative risk is a clinical outcome that lets you work backwards from a relatively rare event, such as suicide, and see the degree to which people with mental illness or another risk factor are overly represented. But if you look at another statistic, something like a population attributable risk, the problem of premature mortality starts to look different. Population attributable risk takes into account not only the elevated risk for an individual posed by a risk factor, but also its prevalence. And what you see here is that because cardiovascular disease is so much more prevalent in everybody, including people with schizophrenia, that the population attributable risk is a much bigger problem for patients with serious mental illness. So if you could magically wave your wand and you wanted to extend the lives of people with serious mental illness, if you could eliminate cardiovascular disease at a population level, it would have a larger impact than eliminating suicide. This is a meta-analysis that was published in 2007 looking at the problem of excess mortality in schizophrenia. And the authors did kind of an interesting thing. They used as a sample, not population sample, but all the studies that had been done over the decades. And what they found was actually a rising excess rate of mortality. Again, we're back to relative risks here over time. So where studies published in the 1970s, you saw about 1.7-fold by the 1990s. The excess mortality relative risks were over 3. And this is, I mean, if you think of studies as kind of representing the broader population, you can think of this like any other disparities problem where you have not necessarily that people with schizophrenia are living less long, but that they are not sharing in the gains in lifespan that were happening during these years for the rest of the population. So this is what happens with disadvantaged disparities populations is you have a rising tide that is not lifting all boats equally. Okay, so I would argue that this problem or our fields thinking about this problem really changed with the publication of a report in 2006 by the National Association of Mental Health Program Directors medical group. And that's important, like who did the report, because the difference is when we're talking about research to practice, when a report is done by researchers, even when they're working for, say, the New York State Department of Mental Hygiene, that's very different from when it's commissioned by the folks who essentially are responsible for providing care at the state level for populations, uninsured, poor populations with serious mental illness. So this was a report that was commissioned by the National Association by these Medical Directors Council, with Joe Parks really kind of being the force behind it. It synthesized the existing data and added a new multi-site study that was commissioned for the report that actually used the exact same methods as Malzberg did back in 1930. And it compared the age of death for clients in the public mental health system to age and sex-adjusted controls from the states. So, what this meant from kind of a policy level is that we as a field were not just saying there's this problem that's out there, we treat mental illness, but it was actually saying we own this problem. We treat the people with mental illness, and this is a problem we're going to have to deal with as a field. And what the finding was that probably many of you have heard is that if you looked across the 7 states and you looked at the average age of death for people with who were treated in the public mental health sector, it was something like 25 years younger than the general population. And this was an above the fold article that was published in USA Today. It got a lot of coverage. Again, I think it got a lot of coverage because it was shifting from this more abstract, like relative risk, odds ratio kind of thing to this years of life lost, way of thinking about it that felt compelling. And it's also a round number, right? So, there's something called the round number bias, and right, we're in the Department of Economics, right, that behavioral economists talk about, when you pump your gas, you tend to round it off to round numbers. There's something about that 25-year statistic that really became very compelling and that really ended up being used to push a lot of kind of policy initiatives that I'll be talking about a little more that moved forward after that. But this was in 2006, this report, with the article published in early 2007. First, though, I want to walk you through exactly a little bit more about this statistic. If you look just in general at what is the effect of having a mental disorder on life expectancy, like a person with, say, depression or schizophrenia versus a person without, there's about an 8-year gap. This is a study that we did actually with Steve back in 2011 that was looking at years of life lost using the National Health Interview Survey. But it's when you get into the public sector that you see this really striking, scary, dramatic gap, and where you have an average. This was a study done using Maryland data, using similar techniques to those from the Nashville report that found average age of death was more like 51, so generation earlier. And just to provide some perspective on sort of these different years, I mean, if you went back and if you think of increasing life expectancy over time, you'd have to go back to 1953 to get to any mental disorder in the general population, and you'd have to go back about 100 years to 1914 to get to a time when the life expectancy in the United States was 51 years. So really a very dramatic and kind of disparity in lifespan. But particularly for the public sector, it almost, and the way I think of it is really it's almost less about what diagnosis you have and more about the sector in which you're treated, and the degree to which this represents essentially sort of the cumulative lifetime and everything, which will be sort of breaking apart a little bit more, of living with a mental illness. But that brings us into then the question of what's going on here and what are some of the causes of this, and how can we think about this, because if you're going to begin to make a dent in this number, you have to kind of break apart what the causes are. This is a pie chart that public health folks like to kind of put forward. Their case and this was based on an article, kind of a back-of-the-envelope estimate that McGinnis and Fahey did back, I think, in 1990. Really that although we, and I, many of us are here are health services researchers focused on the actual care delivery in the formal system, that's really only a piece, and probably a relatively small piece, in terms of understanding overall preventable mortality in the general population. And public health folks, make the case, we really need to think not only about care within the formal health system, but about health behaviors like physical activity, lack of physical activity, and smoking, and poor diet. We need to think about genetics, and we can kind of come back to that. Of course, that's something that, say like NIMH might think would be even a bigger, a very important big piece of the pie in terms of ways, piece that we're going to need to solve, but at least at the present time, probably the hardest to fix. And then there's a whole group, which I really believe is probably even a bigger and more important for disadvantaged populations like people with serious mental illness than the general population, which are the social determinants of health. And that's all the stuff outside of the health system, basically where you live, that has all kinds of downstream effects on your health. So this is an estimate for the general population. I'm going to talk a little bit more about now people with serious mental illness in particular. We did a study using 50 state Medicaid data, just saying if you have diabetes, you're in the national Medicaid system, what are your odds of getting good quality diabetes care in Medicaid? And what you find that is in keeping with some, but not all studies using kind of claims data, is pretty consistently worse care for diabetes care for people who have a mental illness, who have a claim for mental illness, versus people without a claim for mental illness. Smoking, as anyone who's ever done any clinical work in this area, is just unbelievably high. Rates of smoking are much higher. At a population level, having a mental illness takes you from about a 20% odd of smoking to about a 35% odds of smoking. But if you look in any population, cohorts of people with serious mental illness, and this is one that was published in January from the genomic psychiatry cohort, you just see unbelievably high rates of smoking, like over 70%. And again, if you could get that magic wand and wave it and just take one risk factor away for people with serious mental illness, my vote would probably be for smoking, because it's just so much higher, and because there's such a clear association in general between smoking and mortality, not only cancer, but of course cardiovascular disease. Physical activity is worse in populations with serious mental illness. This is one looking at severe psychological distress from the BRFSS, which is a CDC survey that's done using the K6, which is just a generic measure of psychological distress, and you see about a threefold increase in lack of physical activity. Diet is worse for populations with serious mental illness. This is from a meta-analysis that was done in early 2013. And then income, there is a long, very strong literature that shows that there is a very powerful bidirectional relationship between having a mental illness and low income. So there's probably both some degree of downward drift. You have a mental illness, and you lose opportunities to be able to earn as much income, and then of course being poor is also stressful, and so you see this very consistent, robust association. Now, so there are these three factors: healthcare, health behaviors, social determinants of health. But they're not existing independently. They're all interacting with each other. So for instance, if you're poor, you are more likely to live in a neighborhood where you have less access to healthy food and opportunities for physical activity. And that's a food desert. There's also this concept that people are now kind of concerned about is food swamps, which means not only are you in a neighborhood where you don't have good access to healthy food, but you're also in a neighborhood where there are many more opportunities to eat unhealthy food as well. And here's another example of kind of how these factors interact, so the social factors, health behaviors, and in this case, quality of care. So we had done a study a long time ago that was published in 2000 that found that if you had a serious mental illness, you were significantly less likely, and this was even after adjusting for every possible measure of severity or of clinical need, you were much less likely to be offered cardiac catheterization or cardiac surgery. And the way we thought of it at that time was that this was a problem of discrimination. So same doctor, seems two different patients, one has a mental illness, one doesn't have a mental illness. Doctor sends patient without mental illness for cardiac bypass surgery. Patient with mental illness gets less aggressive medical management. But there's another possibility, and this is one that I think is underappreciated when we think about health disparities in general. And this was there was an interesting study that was done in 2013 that found that looked at Medicare claims data and looked at all admissions for heart attacks among Medicare patients nationally. And what the authors found was that having a mental illness predicted a 25% increase in the likelihood of being admitted to a low quality hospital. So, this is a big issue in disparities, and it may be as important in general as the discrimination problem, which is the location problem. If you're a part of a disadvantaged group, you are likely to live in an area where you have less good access to high quality medical care. So there are ways of kind of breaking this apart as best as you can using what's usually cross-sectional data. And we did a mediation analysis, and there's been a small handful of other ones done trying to say if you look at this mortality gap and then you control away for different groups of factors like behavioral factors, SES, or health system factors, how much does the effect size diminish by? And that's a mediation analysis, which is an attempt to try to tease out some of the causality here. And basically what's been found, within the constraints of like how much you can get from these sorts of studies, is fairly consistent with that pie chart that I showed you earlier. So behavioral risk factors explain about a third of the excess mortality. National sample of, that was in a VA sample, and then in this NHIS study that we did that I told you about earlier, SES and health system factors looked like they each explained about a fourth. So the relative risk went down by about a fourth when you added in these factors. And that's fairly consistent. So basically, take-home message is all these groups of factors are important, and they're also probably all interacting with each other. Okay, so let me talk a little bit about then what's going on now in terms of research and also out in the community that's trying to address this problem of excess mortality in populations with serious mental illness. These are the findings from a study that came out last year from Gail Dolmet at Johns Hopkins. It was called Project Achieve. And it studied whether an intensive diet and exercise program could reduce weight in obese patients with serious mental illness. So weight is a really hard outcome typically to move. And it was implemented in psychiatric rehabilitation facilities in the Baltimore area. It was composed of individual and group weight management sessions, group exercise sessions, and also an environmental component that supported staff in these rehab facilities cooking healthier food. And the study found a 6-pound weight reduction on average by the end of the intervention, with an additional pound lost after the intervention ended. So this is great, right? Made the New England Journal of Medicine, 6 pounds, right? I mean, this is not, we're not talking like, you know, the greatest loser here. I mean, these are not like, you know, and this tends to be the case in general for a lot, you know, it is hard to move these outcomes, particularly things like weight. And this is consistent, by the way, with findings in the general population. If you do randomized trials of weight control, you are not finding, you know, 20 or 30 pound weight loss. You're, you know, you need to, you'll feel very happy if you'll get a 5 or 6 pound weight loss. So this is a tough problem, but you know, this was a study that showed it's certainly possible to do it in a relatively controlled setting where you could actually control people's diets with a fairly intensive program. You know, there's interesting things going on out there in the real world, sort of grassroots. This is one that I like that's done back where I did a rotation during my residency, which is a Connecticut mental health center, where the director set up a arrangement with a local farmers market who come in every other Friday and provide healthy, you know, vegetables and fruits both for patients and staff. So it kind of, you know, deals with the environment problem, you know, rather than fixing the social environment out there. It kind of creates a little micro environment around the community mental health center where there's better opportunities for healthy diet. So smoking, I talked about. I mean, it's as I mentioned, it's, you know, really a huge problem for people with serious mental illness. And this was a Cochrane review that was done last year that just looked at all of the studies that have been done in populations with serious mental illness. And, you know, it found significant benefits for bupropion and Chantix in populations with serious mental illness and no adverse effects. So, you know, similar to diet, a little harder to do in populations with serious mental illness, but not much harder, and similar kinds of interventions that you would think about in using with the population as you would in a general population without adverse mental health effects. I mean, we used to think as a field, you know, 25 years ago that somehow cigarettes were like therapeutic and that nicotine was sort of people self-medicating negative symptoms. And, you know, I don't think we think about that anymore in that way. And, you know, there's certainly much more of a push towards thinking about how to get people to quit. And this is actually a study that was published last year in Psych Services. In 2006, NASHMT released a report recommending that all state mental health facilities become smoke-free. And then this looked at how tobacco policies changed after the report from 2008 to 2011. They found that the proportion of facilities making their facilities smoke-free, those are the blue lines, did increase by a lot from just under 50% up to 80%. But what didn't happen as much was the number of inpatient facilities actually providing treatment to help patients get off and stay off cigarettes. So it's easy to do some of these sort of environmental things, and you know, but then what happens to these patients when they go back out into the world? So we have a ways to go. Okay, so you know, most of my work has been focused on this issue of medical care in this population and what are some of the different approaches to improving it. And this is just an example of a study that we did that was published in 2009 that was a case management program. So we took medical nurse case managers. Their task was, you know, do whatever it takes to make sure that people get what they need. You know, they get their primary care service. The nurses didn't provide primary care, but they linked them out into the community. And we found a pretty big effect if you look at this kind of generic measure of quality, which is, you know, how many indicated preventive services should you be able to get, that you were eligible to get, did you get? And part of why there was a big effect is because the baseline rates were so crappy for starting off and also at follow-up. There's a lot going on now I'm going to skip that one. Well, I won't skip it. There's a study that we're doing now that's actually trying to kind of do a next generation of that, which is a partnership between a federally qualified health center or a community mental health center. You're seeing a lot of these out in the community. The federally qualified health center sets up a little shop inside of the community mental health center. And there are a lot of benefits to it, and in a way you get kind of the best of both organizations. There's also a lot of challenges, I will say, in that. And actually this partnership that we've been kind of nurturing for many years in the greater Atlanta area, we're kind of like, part, researchers and part marriage therapists trying to kind of keep this going. And it's very challenging. It's not this idea of sort of talking about collaboration beyond sort of nice feelings, but actually trying to really genuinely meld organizations that often have very different ways in which they're being, but very different cultures and also different ways in which they're being reimbursed can be very challenging. But this is a model, so soon after we had actually started doing that, we were working with a consultant who works, at that time I was working with the National Council for Community Behavioral Health Care. So the National Council is a very effective kind of organizations in terms of policy change, and they were able to plant the seeds of a program that has now turned into something like a $2 billion program nationally, called the Primary Behavioral Health Care Integration Program, PBHCI. And I see Pennsylvania, there are two of them. Are there any of these in Philadelphia? But these are programs that for the most, yes, there is. These are programs that are mostly like that program that I talked about. We're doing that research project, largely built on having a community mental health center take ownership of its patients' medical problems, typically through partnership with a public sector medical provider. But beyond that, there was not, this was like many demonstration projects are, and again, coming back to this sort of research and practice question that we've been talking about, pretty loosely written RFA. So because there was some pressure from the feds and ASPE, and SAMHSA sort of grudgingly agreed to do some kind of evaluation, which is a very small, very modest, small evaluation relative to what's a very, again, very large and expensive program. And actually RAND just released the results of it a couple of months ago. And I would say, to summarize the results in the words of kind of it's a New Yorker, I would say, meh. So what you saw were kind of modest decrease in diastolic blood pressure, that did it, kind of scraped through to statistical significance. The way that RAND did this was they compared 3 case sites, that were kind of picked large, well-functioning ones. So actually, was kind of a fairly, it was kind of wired to actually find an effect, and compared it to 3 control sites and looked at whether patients who were picked at time 1 and time 2 in those 2 different sites, how much they improved. So diastolic blood pressure, again, improved by about 3 points, pretty small, though statistically significant. A small non-significant movement in the wrong direction for BMI, and then again, a very modest improvement in cholesterol. So this is an example. Again, you have a demonstration project where there's sort of very good idea with a lot of resources put in at a high level, but perhaps without as much on the ground kind of focus on the care that's being delivered. And that was the other thing that RAND found was an enormous degree of heterogeneity across the different sites in terms of what they were doing, the number of patients served. I mean, it's very, enormously variable, especially for such a large program. So we're doing some other work in this area. Some of it around, this issue of how you better engage patients in care. A lot of these, even a lot of the these population-based disease models like collaborative care, chronic disease model, largely provider-focused, but particularly for patients with serious mental illness, most of their life, like all of our lives, is spent outside of the doctor's office. So the question is, how do you better kind of engage patients in care? There's this concept of patient activation, which is the idea both of being an effective advocate when you're in the doctor's office and also being able to manage your self-behaviors. And we adapted a program from Stanford that had been developed for general medical populations to be led by consumers for consumers. It's centered around this idea of action planning, which is kind of it predated the chronic disease self-management program, but it kind of is just a sensible approach for any, and if any of you ever want to change it into your own health behaviors, it's the idea that sort of setting kind of general vague goals for your health, like, I want to lose some weight, or I'd like to, exercise more, isn't terribly effective. What does work better is to sort of do the process iteratively, set small goals that you actually think you can achieve. You have a 7 out of 10 or better chance of achieving, and then you achieve it and you feel good about it, and then you set a new goal. And that's really all that it is. And in a pilot study that we did, it did, in fact, look like it improved relative to usual care. How activated patients were, how confident they were in their ability to self-manage their medical illnesses. Okay, I want to talk a little bit about information technology, just because, compared to all the other things that I've been talking about, this actually is an area in which, like, the world really is changing very quickly. This is, the first supercomputer, and it was called a supercomputer in 1964 because it could process a megaflop, which is like floating points of information per second, and it cost $8 million. And now, for all of us who have iPhones, which is most of us, or Androids, they are much more powerful, almost 1,000 times more powerful, and a lot cheaper. So really, this is an area, space in which there's a lot of change going on, in which we've been, trying to think about how, at the very least, we can make sure that people with serious mental illness don't kind of be left behind. We're working, for instance, with Georgia Tech on a game. It's like a diet game. This is the Sweet Auburn Market in Atlanta behind them, and you're a waiter and you have to choose the healthiest food. So it's, that's another, we're also thinking, I think, rethinking, and in part in the context of information technology, how do people really learn best? It's not necessarily just by downloading information. It's about helping them to better engage in it, kind of, through approaches like games. Information technology is very important in multifaceted interventions in general. I mean, it's kind of one of the key things that powers all these collaborative care models that are being used now in general, both for depression and primary care, and also for medical care for people with serious mental illness. But registry is the idea of, you pick what your key outcomes are, and you really focus your care delivery, you focus your resources towards the people who aren't at target and who aren't getting better. So in our case, for that home study that I mentioned earlier, we have a registry that measures, that in which people who are not at target are red, and then we focus our rounds every other week on sort of problem solving. Sometimes it involves, you need to change meds. Sometimes it involves the fact that someone isn't taking their meds. If they're not taking their meds, it might be, for any number of reasons, maybe they're having side effects, maybe they can't afford it, maybe they're having, some other factor. But you really focus your energies around the people who aren't getting better. And we're doing work around this idea of personal health records. We did a study that was, I guess we applied for the grant in 2007, at which point sort of the technology, first of all, there was a lot of interest in personal health records, and the technology was all web-based at that point. And this was a health record that had all of kind of the medical and the mental health information, as well as medications, as well as advanced health directives and advanced mental health directives all in one place. We did a small trial of that and found that was published a couple of months ago, that again, this general measure of quality preventive services were significantly increased in the group who had this personal health record. So now we're thinking, you know, as the world has gone mobile, we're thinking about what sorts of interventions, you know, how to take this kind of technology mobily, and we have a study in which we're using a mobile personal health record that directly pulls on the medical and mental health record in one of these SAMHSA PBHCI partnership groups. So actually, despite the fact that these groups are working together, frequently they have real problems communicating with each other. Their medical records don't talk to each other. So we're trying to do that and sort of solve the problem by having patients be the ones who actually own the data and have it with them. Okay, so every health services talk has to include some discussion of the Affordable Care Act, and I just want to briefly talk about you know, this issue of you know, what the opportunities are, but also what some of the challenges are with the Affordable Care Act in terms of addressing this problem of poor health in people with serious mental illness. You know, people with serious mental illness are disproportionately uninsured or underinsured. So that makes this potential for insurance expansion be really important for the population. This is a map of states that, as of October, I don't know how much this has changed actually, are moving. We're moving towards expansion. Of course, I live in the bright red part of the country, and actually for states that aren't expanding, things will actually get worse because you have reductions in like dish payments for uninsured patients in hospitals, and resources that will actually be lost to states. So, you know, I guess and Pennsylvania is, where are we? Where are you guys? What?
Ready to elect a new governor.
Okay, so you're not there yet? Okay, all right. Okay. The other issue that I just think is a caveat that we need to think about is that expansion of insurance of Medicaid doesn't necessarily translate into access to care or higher quality of care. It's just sort of a first step in the process. There was just a study that came out a couple of months ago that showed that only 43% of psychiatrists even take Medicaid. Well, some of them aren't even, you know, and that's the lowest proportion of any field within field within medicine. So, you know, there's problems of workforce. There's problems with distribution of the workforce. Most psychiatrists are disproportionately centered in urban centers, particularly near where they trained. You know, White Plains, New York is the top psychiatrist per capita in the country. So we really, you know, this issue of workforce is going to be really important. And then this also is, there's also a potential challenge that kind of mirrors what happened when Medicaid was established in 1964. And this was an article by Richard Frank and Howard Goldman and Mike Hogan that, you know, has this sort of, you know, clever title of like, be careful what you ask for with Medicaid. So what they said is that when Medicaid was first established, it had the great benefit of kind of infusing the public sector in states with a lot of new resources, but also had the challenges of kind of medicalizing problems, making it easier to pay for things like medication, but harder to finance a lot of the sorts of services that we know that people with serious mental illness need. And remember, when we go back to that pie chart that I talked about earlier, if we're only going to improve people's access to metformin and kind of medical treatments, we're going to be missing all of the other kinds of services, the health behaviors and some of the social factors, housing, employment, that really kind of feed into this problem and really are also really critical to thinking about and addressing the excess mortality problem in people with serious mental illness. So we just need to watch, we need to be careful that even in states that expand, that as people move over from the more traditional mental health system, that there remains kind of a degree of accountability for them, like we have with the state mental health authorities, and that we're able to look beyond just kind of the narrow medical needs of the population and look more holistically. There are some efforts that are out there that are providing more flexible funding for innovative models. Some of the states that are out in front, like Missouri and Rhode Island, are using these. About over half of these new Medicaid health home waivers, and again, so you're not Pennsylvania? None? Okay, so similar. Georgia doesn't either. We've tried. But, these provide funding of 90% federal match to states for covering patients either who have 2 chronic illnesses or a serious mental illness, and making sure that they get the full range of their medical and mental health needs met. And actually, a plurality of these programs focus only on populations with serious mental illness, and the majority, something like 4/5, have people with serious mental illness as a major focus. So, this health homes and these demonstration projects are really important to populations with serious mental illness, and may, help at least complement, just the expansion of insurance to actually look for more flexible ways that we can fund care for these populations. Things like care managers and provider-to-provider contacts that are, difficult to fund under traditional fee-for-service system. There's a lot of projects that are going on out there, sort of like that PBHCI that I talked about before. This is a map from the Center for Medicare and Medicaid Innovation. They've had round one, they had a budget of $1 billion to fund innovation grants, and those were funded. I think we're waiting to hear about round 2 on those. 15 of the programs from the first round included a focus on mental health. Several looked at ways of integrating services for people with mental illness. But, those programs were kind of, there's this idea of kind of letting 1,000 flowers bloom that underlies these programs. And a lot of these programs sort of popped up, and it's not really clear what they're anchored in terms of evidence-based care. It's not really clear how robust the evaluations are going to be. It's similar to PBHCI. There's, I think, enormous opportunity for looking at kind of these natural experiments that are out there, but we also really we're going to need to understand when we look at these not only what works but also what doesn't work, and what doesn't work is often as important data for policymakers as just sort of hearing of model programs that do work. Okay, so I'm almost done, and I want to end where I began with that study by Benjamin Malsberg, because I really do believe that there's kind of not much under the sun with this issue. A lot of these issues we've known about for a long time. And he said in his study, further progress lies in 2 directions. It is dependent in the first place on the general development of medical science, with special reference to the control of diseases of the heart, The other field of preventive activities consists in spreading the gospel of mental hygiene, which teaches that whether a disease be physical or mental, there is only one rational method of treatment, namely the scientific, and that promptness in the application of treatment is the sine qua non of success. So, thank you. So we have some time. Yes?
I wanted to mention a little element of the Affordable Care Act, which I think can have a lot of impact on young people who may or may not develop serious mental illnesses, which is that former foster youth up to the age of 26 are entitled to medical assistance, regardless of whether your state has expanded medical assistance or not. So regardless of whether medical assistance is helpful or harmful for people with mental illnesses, most people prefer to have an insurance card.
Yep.
And I'm with an organization, we're working very hard to educate the close to 4,000 former foster youth up to the age of 26 in the city of Philadelphia. And for people who, and I'm sure in Georgia, it's probably many people don't know about that either.
Yep, so a few issues in there. One, as you say, it's certainly better to have access to healthcare than to not have access to healthcare. But the other, I think, is this issue that I don't think has gotten enough attention for this broader problem, which is the importance of moving upstream and thinking about prevention. And how, if we're going to get ahead of this issue of this 25-year mortality gap, we're going to have to not only start treating people when they're already adults and have already developed chronic illnesses and cardiovascular disease, but we're going to need to be able to think in terms of prevention. And for me, the challenge, I don't know about you folks who are working in that space, is how do you identify the people who will be the future public sector people in mental health, and are there ways of flagging that early enough that we can really begin to think meaningfully about prevention, and how to think about providing services that integrate both physical health and mental health. And I know NIMH is doing they're doing like the RAISE study and that sort of work. It's not really focused on the health piece, the physical health piece, but at least is trying to do that, do those efforts to kind of move upstream. Yes.
So yes, thank you very much for
Sure.
your talk. I really enjoyed it. There's a study that's getting a lot of press recently, just they looked in Michigan with the Medicaid expansion, and they looked at surgical outcomes for patients with Medicaid and not Medicaid, and of course people with Medicaid have poor surgical outcomes. So maybe I missed this in your slide, but if you look at SMI in the Medicaid population and the general Medicaid population, without SMI,
Yeah.
what's the kind of difference in that?
It's a great question, and I'm not actually aware. I've dug around in the past for studies that have done that and have not really been able to find that. So the question of how much of this of any of these poor outcomes are similar to populations, other poor populations on Medicaid. And of course Medicaid is pretty heterogeneous. Medicaid is partly kids and mothers who are poor, and then is partly people with disabilities who are sicker. But so I have not seen that, but I think that is an important question, is how much, what I would suspect is that a big chunk of the problems that you're seeing have more to do with, the people with serious mental illness have more in common with other poor people, and disadvantaged and stigmatized and all that goes along with all that, than the more specific factors that are related to having a mental illness, which would include either, the genetic loading that people have or antipsychotic medications. I think those are a piece, but it's my own. And then that's reflecting my bias as kind of a public health guy. That's sort of how I think of it.